My name's Leon from MediQuip. I'm here today with my colleague Rebecca at the back of the room, who's going to be videoing in the next few minutes. So if you have any questions about the system you may have in your clinic, or adding something or anything over the next few hours, don't hesitate, just reach out and ask us as well. So MediQuip is a nationwide company, but our head office is actually in Brisbane, and so we do not only the equipment, but we do the full servicing and support of the units, and that doesn't just apply to this system but for all brands as well. So if you've got a unit out there that you think needs validation or servicing, and the ADA policy actually specifies they should be serviced on an annual basis, we do provide that service because obviously with the machines we like to ensure they're operating correctly. It's a bit like getting your autoclave validated or your x-ray validated. It's the same procedure. Other things that I'll go through a few aspects of it this afternoon, such as the pressure regulators and so on as well. We service those also as part of the whole run through we do when we attend to the units. So any questions afternoon, please just reach out to either one of us. So I'm going to go through the units over the next few minutes, and as you can see, we have a digital and an analog machine. So we've got 3 digital machines, but we always bring along 1 analog unit. And the reason for that mostly is because there's always some of you guys that have an existing older analog type set in the practice. So I learned the hard way many years ago, always bring an analog, because there's always someone that has that, and it's good for them to do the practical session with a unit that is closer to what they have. So I'll probably be setting that up in the chair over at the back there when you get to the practical session. So those of you that want to use the analog, just go over to that side, and we'll go through that. But I'll go through both units this afternoon. They both do the same thing. One is what I consider more of an automatic unit versus a more manual type system as well. But obviously you can get the same levels of administration, same flow rates and so on as well. It's just one has a few extra steps in it and requires a bit more input from the clinician to deliver the settings as well, but it's pretty straightforward, and I'll show that. I'll put them side by side when we get to that stage. So just starting with the unit, the basic characteristics, I always like to start with the gas cylinders themselves. Some of you who already have nitrous may know some of this, but it's always good to get a bit of a refresher. So obviously Steve goes through the units and the color coding and so on as well. So one thing you'll notice with everything, obviously everything's color coded for different gases. So white obviously is oxygen, blue is nitrous oxide, and everything has specific fittings for each gas. So for example, I've just disconnected the hoses. You can see they're different sizes as well. Conversely, the regulator also has a different connection for each gas. So you've got these little pins here. If you look at the oxygen one, they're differently spaced. So the whole idea of the separate system is that you can't mix it up. It's especially on a mobile system, you can't do it. On a plumbed-in system, I know Steve loves to give those a few horror stories from the past, and I always try and give a bit more context to that.
I give plenty of context, so it's very rare.
So long story short, Australia has very strict standards, and we've never really had an issue regarding that here. So in a dental environment. So what we have always done, well, everything is cross-checked on installation and gas analysed at the output and so on as well. There's actually an Australian standard for that, which requires a proper checklist to go through all the procedures to do that. So we do still do a lot of centralised plumb systems. So and the reason for that is because obviously with a mobile trolley system, everything's on this. Which is great, but sometimes in some clinics, obviously the room size is not practical. A lot of the time in dental surgery is the actual surgery size. So having a unit in the room, sometimes it's better to have it in a cabinet, and then you can just pull that for each administration as well. And obviously, depending on the frequency of use of nitrous oxide you're using, then obviously having a cabinet mount system again is very convenient, because then you can use bigger gas cylinders, you get more economy of scale and so on as well. But just bearing in mind that we do follow very strict Australian standards for this too, and have for many years as well. So just want to give that little footnote just to let you know that things like that are covered very comprehensively in Australia, and pretty much all the gas installers, I don't know of any in Australia that don't actually adhere to it as well. So with the gases themselves, the gauges, Steve might have mentioned this too, do show the contents of the cylinder, but they do work differently to each other as well. So oxygen works how you would expect it to. When it's full, it's in the green zone, it goes down proportionately, kind of like the fuel tank in your car. Same thing, if it's halfway between green and red, it's half full, and so on as well. But nitrous oxide does work differently. So nitrous oxide, being a liquefied gas, will hold the same pressure, and therefore the gauge will indicate at a full or constant level for a majority of the consumption of the gas. So it'll only start to drop the gauge needle when it's about 30 to 35% left in the cylinder. In other words, you already consumed about 2/3. So just bearing that in mind, if you notice the needle isn't dropping, it doesn't mean there's something wrong with the gauge. It means that that's the characteristics of nitrous oxide, and it doesn't matter if you're anywhere in the world, any system, they all work like that. Bearing in mind that nitrous oxide, and you'll see this afternoon, the majority of your administration of the gas is oxygen. So if you do notice that needle starting to drop on the nitrous oxide, it's not really a cause to worry about the fact that you have to start cancelling patients. You probably still have about 3, 4 or so administrations left in the cylinder for content. So it's a good idea to, as an indicator, get the practice manager or whoever to order another cylinder. Vast majority of places in Australia, you get next day delivery for nitrous oxide. So just continue your schedule if you still have patients booked for administration until you get the new cylinder, and you still have enough capacity as well. With the oxygen, like I say, you are using more as well. And for a lot of surgeries, what I always recommend is if you find that you're starting to use nitrous oxide more frequently, it's always a good idea to have a spare oxygen cylinder in the surgery. So oxygen is quite inexpensive. I think a refill of that size is around $35 to $37 for the gas. Nitrous oxide is actually a lot more expensive. It's about $180, I think. But what I'm basically saying is that the cost of having a spare oxygen cylinder is not large compared to the benefit of you being able to do a quick swap should you need to continue administration as well. So just something worth bearing in mind. The trolley systems we actually provide, you can see these ones are our demo ones, but they always have a third slot for an extra cylinder. I usually don't do it. The reason being because the more cylinders you put on, the heavier the trolley becomes to move it around. But I do have some clinicians that like to have that spare cylinder on the trolley, so we just provide that as is, and you can set it up as well. The other thing worth bearing in mind too, just before I continue on to the units themselves, was one little part on a regulator, which I always like to point out, because this is a service part, and this is handled during the service of the units as well. But if for some reason you suspect there's a gas leak in the system, there is a seal here, which is about the size of a small coin. I can just take it out with my finger. That's the main seal between high gas pressure cylinder to the regulator as well. So if you do suspect there's a gas leak in the system, if you hear a hissing sound or you just feel that it's consuming more gas, most often than not is that little guy, that little seal is the main cause of it. And you can see it's very easy to change. I can pull off with my finger, you can put a new one in, like so, and just go straight on as well. They're not expensive, obviously. It's about $6, I think, for that seal. So it's not like it's a huge cost outlay, but it's just worth bearing in mind to know that that is going to be almost most often the cause of a gas leak in the system. So it is, like I say, it is handled as part of the procedure for the service and validation, which is done. But if for some reason it hasn't been done, there's no service been done for some period of time and so on as well, I get the occasional phone call when someone hasn't had it serviced, there's a gas leak, always point them in that direction, and that usually solves it as well. Just something to bear in mind before I move on is with the cylinder as well, if you do suspect there's a gas leak, an easy way to check is have the gas cylinder open, the gauge will indicate, close the gas cylinder, and the needle should not move because there's still pressure in the line. If the needle starts dropping, that's an easy way to check there's a gas leak somewhere. as well. It's just a really easy way that you can do yourself before you start worrying about, ringing up the company and so on to get someone out to have a look at that. You can easily check that by yourself before moving on as well. So those are the gas cylinders. Does that all make sense? Is there any questions on that? Thank you. So with the units itself, I'm going to go through both units, but I'm going to start with the digital machine because, quite frankly, it makes a lot more sense and it's easier to understand the administration characteristics. And then I'll compare the analog one as well. So with the unit itself, gas is on, we turn the machine on, we have two major numbers here. We have the greenish, yellowish button display here on the right-hand side, and the blue on the left. So on the right, this is the gas flow, total flow rate of the machine. So when we turn these machines on, they start at a default flow rate of 5. That's in liters per minute. So at the moment, this machine is indicating 5 liters a minute total flow rate. The left-hand side is giving you the nitrous oxide content of the gas flow in percentage. So when we turn the machine on at the initial rate, we have 100% oxygen. So 5 liters a minute, 0 nitrous oxide as well. You can also see here there's two smaller numbers. These are the individual flow of each gas. So the white, matching the gas cylinders, is oxygen. The blue, once again, is nitrous oxide. So as we add or change the overall flow rate, it will correspond the numbers here. As we start introducing nitrous oxide into the mixture, and you can see, let's say I'll put in 25%, you'll see that the overall flow rate is still 5 liters a minute because we haven't varied that. But on this machine, if you can see the smaller numbers, the oxygen has reduced in proportion to the introduction of the nitrous oxide we're adding to the mixture. So these two smaller numbers will add up to the overall flow rate. The machine is balancing the gas as well. The reason why it starts at 5 liters a minute as an initial flow rate, because that's more or less the base gas flow you'll have for patients. You're starting around 5 liters a minute. I do get the question a lot, is how do I know what a correct gas flow is to match the patient's breathing as well? So there's two things there. Number one, that's where the bag comes in. So the bag is a really good visual indicator of the gas flow from the machine comparative to the patient's breathing themselves. So ideally, you want that bag to be kind of what it is now, about half to 2/3 full and constant. If it's filled up like a balloon, like completely blown out, that means there's more gas being delivered by the machine than the patient is actually breathing. That's not so critical other than the fact you're just blowing off gas, because the patient's not actually getting too much gas. The patient's breathing at their normal rate. There's just more gas coming from the machine than what is needed. So all you would need to do in a circumstance like that, if that bag was completely filled up, is just reduce it maybe 1.5 or so liters to compensate for that, and then it'll balance out as well. A more critical issue is if the bag is completely empty. So if it's completely flat like that, basically, as well, because that means the gas flow from the machine is not matching the patient's breathing. So the big takeaway from that is the patient's not getting an adequate gas mixture to have a valid sedation level as well. So you could be dumping this up to high flow rates, but there's not actual enough gas flow to match the patient's breathing. Having said that, you're not going to be suffocating a patient as well. So all machines have, and this one's easy to show because it detaches, has a little valve here. This is called a room air override valve. What this is designed to do, it allows room air into the flow to the patient if the gas flow from the machine is inadequate. So the patient's not going to be deprived of breathable air, but obviously they're going to be breathing room air. So once again, not an adequate sedation level, but at least the patient's not feels like they have to struggle to breathe as well. So I do get asked a lot of the question, what level should I start with? And actually on digital machines, it can be a bit lower than analog. You'll probably see that this afternoon, simply because these machines are more efficient. But a very general rule is take a patient's body weight divided by 10. So if a patient weighs 50 kilos, you'd start at 5. If they weigh 70 kilos, you start at 7, and so on as well. Once again, that's subjective. The patient may have other pre-existing conditions that will contribute to that, but it's like a reference point. It's like just a general rule of thumb. And once again, once you start your flow rate, you're then judging by the bag as well. So it's pretty straightforward from move on as well. So we can add our nitrous oxide. The maximum we can administer with any machine in dentistry, because these are called relative analgesia units and not anesthetic machines, is 70% as well. So when we max out 70%, I'll demonstrate on the analog the same thing. This is the maximum we can administer to the patient in terms of nitrous oxide percentage. So we've always got a minimum of 30% oxygen going to the patient at any time, which is one of the reasons why nitrous oxide is actually particularly safe, because even at that high level, we're still giving about, I think it's about 15% more saturated oxygen than they're getting from room air, because obviously the mixture. So bearing in mind that that's the maximum we can do. And once again, you can see we can change the overall flow. Once we reduce, the machine's doing compensation for you as well. The maximum we can go on a digital machine is basically 10 liters a minute. I can't recall ever having to go higher than that as well. I've had a few dentists on courses, I think Steve probably remembers this too, where either they're marathon runners or scuba divers or something like that. So I mentioned that body weight to flow rate ratio, they were way obscure of that. Like someone weighed like 60 kilos and they were breathing at 8 or 9 liters a minute. So once again, it's a reference point and you'll go from there as well. So that's how that unit operates. Does that make sense at all? Is that okay? Can you see that? Cool. So I'm just gonna go down to where we started. Where am I? Here we are. Because I want to show the analog machine back to back. So here, like just to repeat myself for a minute, overall flow rate, nitrous oxide percentage. On this machine, we have a main control which controls the total flow rate, same as that, and the left-hand collar is our nitrous oxide percentage. And you can see on the little black bar, and if you're working on the analog this afternoon, you've got the indicator nitrous oxide percentage levels there. However, a couple of things worth bearing in mind with that unit. So at the moment, let's say you've got 2 flow tubes here. This is giving the flow of each gas individually. So on the right-hand side, looking at it from behind so we can work it out, this is the oxygen level in liters per minute. The left-hand side is our nitrous oxide as well. So at the moment, we are indicating 5 plus 3. So the overall flow rate is 8. We have to add them together to get what we would have normally on main display here as well. Other thing to bear in mind with an analog machine as well. So let's say we set 5 liters a minute. I'll do this back to back. There we are. So 5 liters a minute. We want to add, say, for the sake of this example, we want to add 30%. Because it's easy to see. I add 30% to 30% here. I'm getting a 30% mixture, but you may have noticed in order to achieve that, the machine has increased the nitrous oxide to a level to get to that 30% mixture. However, the oxygen is still constant. So we've gone from 5 liters a minute to just about 7 as well. On this machine, if we went to 20%, you'll see that the machine has reduced the oxygen in proportion to it. This one, you just need to give it a bit of an adjustment as well. That's one of the main distinctions between an analog and a digital machine as well. So you still have your 7% maximum flow rate. I can easily check that by going 3 liters to 7, so 70%. We can do the same levels of titration and so on with this machine, but you have that extra step involved as well. And once again, you probably notice it's not as clear to see what it's actually doing. Where this machine, you've got a nice big number to look at as well, and it's easy to chart what your sedation levels were. For example, if you were taking a patient record here, but at 5 liters a minute at 20%, you'd probably have to add maybe the individual flow rates for each one and so as well. So it's a bit more involved in order to achieve the same thing. That's why I always like to use the example, this is more automatic versus more manual as well. Another thing worth bearing in mind with a digital versus an analog machine is is called the fail-safe. So all these machines will not function without oxygen being present. So in other words, the machine will not deliver 100% nitrous oxide as well. They're designed to shut down. Now, what a digital machine has, just to use an example, if I turn off the gas, if I turn off the oxygen, so the nitrous is still on, turn off the oxygen on both, with the nitrous still being on, you'll see that the little needle will start dropping. There it goes, here and here. But you'll see this machine will give you an alarm. In other words, it will start beeping and give you a message, failure oxygen. On an analog, you see this is what's happened is it stopped working, but it's just shut down. It hasn't given you that indicator, where this one will tell you as well. The reason I mention that is because it actually is relevant a lot if you consider the current ADA policies and standards. They should have an audio and visual alarm as well. So for a mobile system, a digital machine will cover that. With an analog machine, we do a lot of centralized systems, so the alarm can be built into the gas control panels and so on as well, which makes it compliant that way. But on a mobile type system, only a digital system can really make that distinction as well. So just something worth bearing in mind as well. Final things on the machine before I move on to the tubing and the hood and so on as well, is there's one button here on the unit, and this is called O2 flush. What this is designed to do is for any time during the procedure, if you wish to reverse the administration quickly, and it could be due to a patient's not comfortable with the nitrous oxide or whatever. Once again, oversedation can be the main cause of that. You press and hold O2 flush, and it will shut off. You'll see it'll shut off nitrous oxide automatically, and you can hear it gives you a high flow of oxygen for as long as you hold down that button to allow the patient to be purged of nitrous oxide quickly as well. So all machines have that, all the way up. Even if you look at the hospital anesthetic machines, they all have a big O2 button, O2 flush button as well, and that's there in case you wish to reverse the effect quickly. And for normal administration, you don't really need to use it. But it's important. It's like a fail-safe button again. It allows you to reverse the effect quickly. Once again, that's one of the big advantages of nitrous oxide is that the titration level, both setting in but also can also be reversed very quickly as well. It's probably the only drug we use in dentistry that actually will provide that as well. So that's there in case you wish to reverse it quickly. You can use it post-administration just to speed it up a little bit, but most of the time you're just wasting a bit of gas.
What is the flow rate?
It's about 30 litres a minute. So once again, that's tested when we do the validation as well. So we were administering at 5 litres a minute. All of a sudden we go from 5 to 30. The patient gets a good rush of oxygen, and it allows it to be purged very quickly as well. And all machines have that also. So does that make sense between those units? Any questions at all?
Is the analog machine regulation compliant?
Yes.
Though it's not originally.
Yes, it is. It's just bearing in mind that fail-safe is on the ADA policy, and that's why I pointed out for the digital unit as well. So, majority is, if you've got older unit out there, if the machine has the other fail-safes operating, and that's part of the validation process, I say that's okay. But if you are looking at a new machine, it's something I would consider as part of the upgrade process as well. Does that make sense?
Yeah.
Cool. So moving on, just going to turn these guys off so I don't waste some gas. With the units, obviously this is the administration of the machine, but for the patient perspective, the hood is the nitrous oxide device as well. So this afternoon we're using the Clearview hoods. So these are ones which are used. I'm not sure if any of you guys have ever seen that type of hood before. If you work at Pacific Smiles or the Bupa clinics, they're very common through those clinics. Queensland Health uses them as well. But the big advantage of these hoods is that they are single use. But the big advantage clinically is a couple of things. Number one, they're all lovely coloured, they're all flavoured and scented and so on as well. Sounds like a bit of a gimmick but from a patient point of view, it's part, and obviously the whole point of a patient is nitrous oxide in dentistry, a lot of that is patient anxiety. if you give them something they can relate to, it smells nice instead of an old tire that's, it's been through autoclave 1,000 times, and I've seen some great ones over the years. It's all part of the experience with nitrous oxide. So when we get to the practical sessions, there are the hoods. You'll grab a hood this afternoon. The middle hoods, the green ones are the standard adult size. And you can get different flavors and scents. This is mint, which is probably the most popular. You can also get other ones as well, but if you do find you need a larger hood than standard, on the left are the white ones, they're vanilla, large adult, and on the right, the pinky ones are small size, mostly pediatric, but I bring them along. Sometimes we get a few dentists on the day who actually suits them as well, so just choose which one's best for you when you get to that point. But the big advantage of this hood clinically is that, and it's called clear view for that reason, you can actually see through the hood, and you can see the patient breathing through the hood as well, because the inner part, which is the colored section, is what the patient breathes in, but as they breathe out, they breathe through the outer section. And you can see there's two things you'll see. You'll see that little disc here, that's the one-way valve. This is what the patient breathes in and out, and actually separates the gas mixture between the exhaled breath and the inhaled breath. You'll see that moving ever so slightly, and you'll see that this afternoon. A lot of the time, you'll even see a layer of condensation on the inner wall of the hood. Once again, that's validating the patient's breathing consistently through the nose. And it is very useful. And the reason for that is because one of the things with nitrous oxide, obviously in dentistry, we're delivering it through a nasal hood. So we want to make sure the patient is breathing consistently through their nose as well. And there's been a number of times where the patient breathes through the mouth and the clinician doesn't detect it. It's not an adequate dosage, so the patient's not getting an adequate effect. And I've actually had phone calls about this. I had a really good one a few years ago where it was a regional clinic in New South Wales, and we delivered the system and we did the instruction, and about a week later they rang me and said, oh, we had a staff afternoon day, so we thought we'd try it out on each other as well. And it wasn't working. I said, okay, let me ask you a question. With the staff afternoon, everyone was talking and laughing and having a good time, including the person you were trying to administer. So next time you do it, just make sure the person you're administering just breathes through the nose consistently. And I think they rang a couple of weeks later and they said, yeah, went perfectly as well. So it makes a big difference the more they breathe through the nose. So if you can actually verify they breathe through the nose consistently, and that would allows you to do it, is conducive to a much more effective administration for the patient as well. So just something worth bearing in mind. And so you see that this afternoon. They're compatible with all brand systems as well. You can get adapter kits forward and so on as well. We do that. A lot of pediatric dentists really like this hood, because obviously telling a child to breathe through the nose and actually having them breathe through the nose is sometimes easier said than done. So if you can easily verify that visually, it takes away all that guesswork as well. So we'll get to that. So how that works with the tubing set we're using this afternoon is this just connects to the front of the machine, and the hood, you can see there's different size tubing, so the ability to get it hooked on back to front is nigh impossible unless you really want to do it, and basically just pushes straight onto the tubing. It doesn't have to go on all the way, just so it goes on, so it's nice and secure, and that's what goes on the patient. You've got a little tubing slide here, and that goes around the backrest of the chair to allow the hood to fit securely. It doesn't have to be locked down on the patient like it's like a torture device, just so it's fitting nice and securely. And thanks for laughing at that. And then you just leave it, let it run in the background as well. One thing this afternoon I just want to point out is we're not using dental chairs. We're using these, I don't know, these camper chairs. So it's wider than it would normally be. So in a dental chair, actually, you don't necessarily, you have a fit easier to achieve than maybe this afternoon. Just bear that in mind when we're doing it as well. With the tubing set too, and we're not using it this afternoon because obviously, once again, we're not in a dental surgery. All systems are supplied in Australia and have been for 30 plus years with scavenging. So scavenging is the removal of a patient's exhaled gas from the surgery. This is, like I say, it's been a long argued issue in dentistry, but the long story short is it's been a requirement for many, many years, and it's designed for the reduction of long-term exposure to the dentist, clinician, and assistant and the dental team. It's not a reduction of nitrous oxide to the patient, because obviously the patient, it's their exhaled breath. So this normally, and like I said, we don't have to use this afternoon, it's only for a few minutes, we're using it at a time anyway, just fits onto the tubing connection here, and this connects up to a vacuum source. So this either connects onto a dedicated vacuum port or saliva ejector or whatever you have spare in the operatory for suction connection, and it basically just removes the gas trace levels from the patient's exhaled breath, and if there's any leakage around the hood, and it's obviously there to reduce the exposure to the dentist and the assistant as well. So just want to bear that in mind this afternoon. It's been a requirement for many years. Occasionally we come across a surgery that hasn't got it, so you may not just like to check that if you've got an older system in the practice as well, but you can retrofit it to existing machines as well, just worth bearing in mind. So before I hand over, something came up during the lecture, I think it was yourself, regarding silhouette hoods, was that you?
Yes.
So this is an equivalent type system, very similar to silhouette, low profile hoods as well. This one's a bit different to silhouette because the tubing is fully autoclavable, so it's just the hood you change over, so its cost per patient is a lot cheaper than that type system as well, which is around $25 a patient. It's quite expensive. That's under 10. But having said that, low profile hood is the big advantage of this system, and one of the discussed disadvantages of a traditional hood is obviously it can be cumbersome on the patient as well. So blocking access, especially if you're working on upper anterior or so on as well, then you may find it's a bit of an obstruction for you. So low profile hood is designed to be smaller in size. It fits around the profile of the nose. The tubings go around the ears like an oxygen cannula, if you can visualize. And it just is smaller in overall size. They do work a little bit differently, however, and this is something I think Steve mentioned as well. In order to get a hood that size, you don't have the breathing valve as well. And by not having the breathing valve, the bag is not able to be used as well. So you're dispensing with the bag. And you'll see this afternoon, the bag is very helpful because it allows you to visualize what the patient's breathing rate is versus the delivery from the machine. So you can actually cap that off, and so the flip side of that is your flow rates tend to be around 30% higher than what you would be using with the traditional type hood and bag system as well. They're very good for patient size. Like Steve mentioned before, I usually recommend them for dentists who are well experienced with nitrous oxide because they know their flow rates. They've got a good background and understanding of what the patient would be breathing and what the indicators are. And I do have a lot of patients that have both systems, so if they do have an issue for uppers or something like this, they go to this system, but they use traditional hood otherwise.
Do those hoods have the nasal prongs?
No.
Because I found those difficult to use.
Yes, they do not as well. And I'll give you a few samples before if you want to have a look at it. So feel free to ask as well. So this is an alternative silhouette on this. They work the same way, but that's the one distinction between that and a traditional hood system as well. So I just wanted to mention that because it came up in the lecture as well, and I do get asked about it quite a lot. We do have a lot of surgeries that use it, but like I say, if you're new to nitrous oxide, I always like to use the traditional hood because it's so much easier clinically to administer with as well. It's just worth bearing in mind. So before I head back to Steve, one more small thing as well is that these systems have one nice little feature on them as well, is that you can also have a connection. It's either there or on the side here. So it just plugs in for a full face resuscitation mask as well. So this is not to do with the administration for patient analgesia. This is to do if the patient stopped breathing in the surgery. It's pretty much a enhanced version if you've got an oxyviva system in the clinic as well. Instead of having a bag to squeeze, it has a demand valve, so it's there to administer positive pressure resuscitation. So if the patient's not breathing, it actually will give you 100% oxygen at a good flow rate to allow you to do a really effective resuscitation of a patient should you be in a medical emergency that would require it as well. So just worth bearing in mind, it's available to fit all these systems that we supply as well. So that's about it really. Is there any questions before I hand back to Steve?